Hi, everybody. We're going to go ahead and broadcast real quick and let roll in. All right, welcome everybody. You have joined us for our pandemic recovery series. This is session 3 of 8. It's put on by Knight CPA Group, Healthcare Consult Link, and DLA Piper. We've got Charity Farnsworth with us, Heidi Wall, and Richard Chin. Those will be your presenters today. I'll just be sitting in the background, launching the polling questions, and then I'll help out with the Q&A. So what's next on our slide, Charity? So we just got a quick disclaimer that none of us are properly engaged for services through this webinar. So make sure if you need help, you engage somebody to get help with you. And we just want to go over briefly what the upcoming sessions are. So this is number 3 of 8, and we'll get to that agenda in just a moment, but it is identifying the operational efficiencies during pandemic recovery. Next week will be a financial session over getting prepared for the next round, financial considerations. And then on July 30th, we'll go legal aspects of pandemic recovery. August 6th, setting yourself up for financial success. Number 7, addressing pandemic psychosocial impacts while rebuilding agency operations. And number 8 is going to be optimizing external opportunities for agency growth and expansion. So a little bit more about what today's session is it's going to cover the labor and employment factors related to COVID-19 pandemic. Look at the telehealth legal regulatory aspects and clinical implementation, and then optimizing key operational processes, and we will wrap up with Q&A. So I will let everybody introduce themselves, but before we do, I want to do a little housekeeping because I tend to forget this. We do ask that all questions go in the actual Q&A panel. I believe it says Q&A. So down at the bottom of your toolbar for Zoom, there's a Q&A box. If you click on that, it'll pop open a box. Please post your questions there. It allows us to track them and actually mark them answered to know that we got everything answered. When you post a question in chat, it doesn't work as well and it's a lot harder for us to find. Speaking of chat, we did get the handouts uploaded to the website right before launching, available. So I'm going to put the link here in the chat box and everybody can grab them if they like, or just go online and see them. So that's going out to all panelists and attendees. So there's a link right there to the slides, as well as the entire website that houses all of the registration links and everything for the presentation. What's next? All right, I'll let you guys introduce yourselves.
Great, thanks Amy. My name is Richard Chang. I'm with the law firm of DLA Piper. I am a healthcare attorney that primarily represents healthcare providers, investors, and operators on the management side in various capacities. Today we're going to be talking about a variety of issues, but for my part, it's going to be very focused in on the labor employment, and also it'll transition into telehealth. Very excited to be here. Thank you for the opportunity, and thank you for coming to listen to us and making the time. And hopefully you'll find this educational and useful in your business. Next. So let's start off by just talking about your business. And the climate of COVID-19 has obviously shifted our frame of mind and how we do business. And there are a lot of moving parts on how to deal with all aspects of your business. And, a big part of it are your employees. Before I dive into the labor employment section, just as a consideration for your business during COVID-19, I highly recommend for all businesses to really understand what their state and local orders are. Clearly, it changes and it varies from city to city, county to county. I understand there's probably some individuals on this webinar that's from a different state. So I believe last time we had someone from Kansas or some other state, and if I'm wrong, pardon me, but obviously the point is that from jurisdiction to jurisdiction, it varies. So you should be aware of what your own jurisdiction looks like. And part of that is also driven by transmission rates, just the local government, and the overall culture of that area as well. So some of the plans for local orders or state restrictions may be shifted, maybe dictated by hospitalization rates and public health impacts. Also be aware of just the overall guidance from the federal government. A lot of times that could have a very big driving force in what goes on locally. And the whole point of that is really just to maximize readiness, right? Is that you just want to be ready. You certainly don't want to be reactive. You want to have an opportunity to plan ahead. Next. Okay, so going into the actual labor employment section of looking at COVID-19, how to prepare and how to transition. And of course, at this point, it's mid-July. A lot of you have already adapted. During this pandemic, everybody has been forced to learn how to adapt. But what does it look like when you're bringing people back, as you're bringing employees back? Maybe some of them are getting sick if the pandemic gets worse. And so again, a lot of moving parts. In general, I recommend employers to that they have to have an understanding that they do have a duty to ensure a safe and healthy workplace, pursuant to OSHA guidelines and also CDC guidelines, and of course local guidance ordinances. Some of the issues that come up when preparing for a safe working environment as a home healthcare agency, or really any employer, is to look at your administrative controls. What are you doing? What aren't you doing? As far as putting the right people in place, utilizing the right policies and procedures. Are you utilizing good work habits? What type of supplies, such as the personal protective equipment is in its availability? Is that going to be an issue? And also engineering controls, such as screens and different arrangements, with the physical arrangements within your office. You should look at the characteristics of your workplace, how workers are exposed to risk, and who are your essential employees versus who are not. So taking the step to assess it first, and then once you've assessed it, you can then identify some of the issues, then you can plan ahead. By planning ahead, you can look at, again, it's going back to supplies, right? The personal protective equipment, do you have enough masks? Do you have enough gloves? Looking at workplace modifications. Maybe it means changing some of your cubicles around. If you do have cubes, maybe it means shifting some furniture around and spacing it out a little bit more, changing your policies, and looking at how maybe it's time to update your policies. So be aware of what your policies are, because one thing I do recommend for employers is to be consistent with your policies. Whatever you do today could very well set a precedence for what you do and don't do in the future. Training and communication staff is absolutely critical. As far as social distancing, the list I provided isn't exhaustive in nature. It's there's definitely more, but here are some considerations when when it's feasible to exercise social distancing within the office. Looking at location flexibility, if you have an employee that is able to work from home, that's something to consider. Not all employees are appropriate for that, given the role and given the employee. But that's something you should consider. Staggering shifts. So if you're used to having a shift that has, say, I don't know, 5 people in an office, and I know given the nature of home health, most of your workers are out in the field, but a lot of times workers could overlap. So let's say if a therapist goes into a patient's home and the nurse is leaving, well, maybe you should emphasize to your employees to exercise better communications to ensure that there isn't any overlapping, so that you're just taking that one extra precautionary effort to minimize that the employees crossing paths. Not to say they don't like each other or anything, but it's just a simple matter of mitigating risk. Increasing physical space within your physical offices, being mindful of just keeping your distance from other individuals, if you can, obviously. Modifying physical layouts, and think about face-to-face contact. That's another one. Next. So how are you screening? Look at your policies and look at your practice to see how you're screening, how often you're screening, who are you screening. Really ask yourselves why you're screening that person. Is it the person that tells you that they've been exposed, or are you screening everybody? Because there are some restrictions under ADA on if you go on a very broad sweeping effort to just screen everybody. There's a right time to screen, there's a wrong time to screen. So you should have a policy about that. You should work with a professional on when is it appropriate to screen somebody. Again, keeping in mind some of the restrictions under the ADA guidelines. So if you look at the CDC website, they do provide guidance on how to specifically handle asymptomatic and symptomatic employees, and they do provide guidelines on how long to keep an employee quarantined and the step-by-step process. Now, keep in mind, these are just guidelines. So just because you don't follow CDC guidelines doesn't mean that you violate the law. But by following CDC guidelines, you can, one, claim that it's best practices if there is litigation that ensues, and two, it just creates a better compliant culture internally. It is, again, it goes back to mitigating risk as from the employer side. I just actually had this come up recently. Involved a physician who actually tested positive, and then later on tested negative, but the employer didn't feel comfortable bringing him back right away, and he actually came up to the office and insisted on working. And we actually had to intervene, or I had to intervene in conjunction with the HR department. So that kind of stuff does come up, believe it or not. But you just have to handle it on a case-by-case basis, because every set of facts is a little bit different. Consider your leave policies, and consider some of the new laws that's been in place under the FFCRA. And within the FFCRA, you also have the EFMLPA, or I have it written down, the Emergency Family and Medical Leave Expansion Act. It's a very long word. And then you have EPSLA, which is the Emergency Paid Sick Leave Act. Those are all rather new pieces of legislation in response to COVID-19. And of course, one provides an expanded leave if you've been an employee for 30 days or more. And that's really focused on the ability to provide care to kids who can't go to school, or the caretaker can't come to provide care because as it relates to COVID-19. So all these different laws has to be tied. It has to have a close nexus to COVID-19. It can't just be for any reason. So EPSLA, the Emergency Paid Sick Leave Act, it gives you up to 80 weeks of leave. Now there's really two tiers. It's tier one is for a certain set of circumstances that you can use up to 80 weeks and you're paid. And then the second sort of set of circumstances, or the second set of reasons why you need that leave, is because of provides you at 2/3 pay. The first one that I mentioned is really related to the worker, him or herself, because an employee can't come into work because of quarantine, or because they've contracted the virus and they're showing symptoms and they simply can't work. That does provide some protection for up to 2 weeks. And that's for any employee. You don't have to be an employee for 30 days. So that's really the differentiating factor between the two. Be aware of paid leave obligations within your policy. So also, if your policy says something or there's something state specific beyond these federal pieces of statutes, be aware of that as well. Next. So policy changes, revisit and assess your policies. I've already said that. So when you're selecting an employee to come back to work, or you're selecting an employee to leave work, really ask yourselves why you're doing it. And it should really be based on a legitimate business reason. everybody has a different legitimate business reason. Again, it's very fact specific. So there isn't really, I can't really sit here and tell you these are the things that you should and shouldn't do, but you should keep in mind as a foundation, why am I doing this? Is it tied to a legitimate business reason? Is it related to the protocols and policies of my company, or is it for best practices to grow the company or to minimize risk so that other people don't get sick? So you really have to ask yourselves why you're doing it. If an employee comes to you and says, hey, I'm concerned about COVID-19, or I don't think I should be working because of this, or I've contracted something, engage in that discussion with the employee. The practice is very similar to that interactive process under the ADA. You really should be engaging it. That's really the first step. And of course, document it and provide a paper trail of that. The goal is really to foster a compliant work culture and to mitigate risk as a whole. Next. I think we have to get a polling question, right?
Sorry, guys. All right, let me launch this. This is the one for Richard. There it goes.
So of course I had to make it a little bit harder on everybody because I don't know, I guess I was being test sassy, but really the question is, which of the following is considered a social distancing consideration for your employer? It's either terminating your employee, putting the employee in a hazmat outfit, allowing location flexibility, increasing physical space, or both C and D, or really the, when I mean say C and D, meaning allowing location flexibility and increasing physical space.
Everybody's voting. Let me give them just a little bit more time. All right, let me go ahead and close it. I'll share the results with you.
All right. The most everybody was correct. It is C and D. I was really hoping at least one person would pick the hazmat outfit because you guys disappoint me, but oh well, you guys were too smart for that. So.
All right.
Okay, so let's really jump into telehealth. A very different topic, and it probably doesn't have as much direct impact on your day-to-day operations. Nevertheless, it is indeed impacting the industry, and it could have some permanent effects later on. So what is telehealth? It's a very broad definition. I don't really have to read it verbatim. It's right there in front of you. That specific definition is actually provided by the Health Resources and Services Administration of Department of Health and Human Services. Very broad. If you go to different resources, they'll define telehealth differently. And just to let you know, telehealth is slightly different than the definition of telemedicine. Telehealth generally has a much broader connotation to it, and has a very it has a broader application to it. So just to give you a little bit of background, telehealth has generally been very restrictive under Medicare guidelines as from a payment standpoint, and even up until 2017, it was very restrictive even on the licensing standpoint. It wasn't until 2017, at least in Texas, a fairly landmark case in Texas came down to where it eliminated a lot of the restrictions on how physicians can use telemedicine, which really falls under the umbrella of telehealth. But as it relates to COVID-19, in March earlier this year, CMS expanded telehealth on a temporary emergency basis under the 1135 Authority and the CARES Act. Next. So if you look at the waivers, the blanket waivers that was provided for specific to home health. And I believe we've already talked about waivers in a prior discussion, but if you look at all the waivers, there were 10 very specific waivers in the first round of these 1135 waivers, and not one single waiver mention telehealth or telemedicine or use of telecommunications, with the exception as a whole, OCR, which is Office of Civil Rights, talked about HIPAA and talked about how they're going to use their discretion to loosen the enforceability of HIPAA. That's really what they talked about. They didn't really tie home health to telehealth as a whole. So originally the waiver came out. Medicare said, "Hey, we'll pay for office for telecommunication services or telehealth services starting March 6th," and they provided a list of providers, including doctors, nurse practitioners, clinical psychologists, and so forth. It wasn't until later they actually expanded it. I believe the expansion date was on April 30th. That's the expansion date that went into the therapists. That's when OTs, physical therapists, and speech language pathologists were able to utilize telehealth. So prior to the waiver, Medicare would only pay for telehealth on a very limited basis, like I said, and it was specific to a person receiving the service in a designated rural area, and that has a very specific statutory definition to it. And when they leave home to go to a clinic, hospital, or certain other types of medical facilities. So I do want to emphasize something. When a patient goes to a clinic, hospital, or other medical facility like a SNF, that is what's called the originating site. With the distant site, you'll hear these two terms a lot in the world of telehealth: originating site and distant site. It's a little counterintuitive because the distant site is actually where the physician is, and the originating site is where the patient is. The rub has always been where the originating site is, meaning, does Medicare pay for telehealth services if the originating site is at home or if it's some outside of the approved list of originating sites, such as a SNF or a hospital? So this is where it gets a little bit more interesting. Next. Okay, so really telehealth, going into the COVID-19 era, they really emphasize real-time communications. It can be over the phone. So before, you couldn't really talk over the phone for the use of telehealth. You had to have like a two-way video, or what they call a store and forward. But because of telehealth, now the two-way communication can be just audio. Like I said, none of the blanket waivers really mention telehealth as it relates to home health or hospice. And then it got expanded to it got expanded on April 30th, allowing hospitals to provide services at home, COVID-19 testing without physician orders, and it went into therapy services. Ultimately, because of this, there was a gradual increase in LUPA payments, because you couldn't really bill for it, but yet at the same time, you could use it for therapy services. So what does that really mean? It means that there's a very specific statute. It's under the Code of Federal Regulations. It says that if telehealth is part of the patient's plan of care and does not replace needed in-person visits as ordered in the plan, then it's fine. And so ultimately, only in-person visits can be reported on the home health care or on the home health claim. So effectively, if you think about it, right, you can use telehealth. You can do it to monitor. You can use telehealth to check up on patients. You can use it for a variety of different reasons. But if it's within their plan of care, and it's indicated in their plan of care that they need telehealth, but the actual treatment itself still needs to be in person, you can't really bill for that. What it did do with telehealth is that it can be, the two-way audio video communication can be used in lieu of the face-to-face encounter for physicians. And of course, I talked about HIPAA loosening its restrictions, and basically OCR said, as long as you're using good faith efforts to maintain the confidentiality of the information, we're not going to enforce. And what that was focused on is, if you're using FaceTime, which you can use FaceTime under the temporary orders in response to COVID, is that if you're using FaceTime and you're out in a very public area, that's probably not a good judgment on a good faith effort. But if you're using FaceTime and you're making a good faith effort to minimize the people that's exposed to that, then the OCR will look at that. By the way, OCR is under the umbrella of HHS. So sorry if I use HHS and OCR interchangeably. OCR is simply an agency within HHS. Next. So CMS has issued a proposed rule in late June, and it was actually published on June 30th. What it really did was, and right now it's open for public comments, to make some of these regulatory changes as it relates to telehealth under Medicare guidelines to be permanent. And so we don't know if that's going to be the case, but if it is, obviously it could change the industry quite a bit. Home healthcare agencies will be able to continue using telehealth with beneficiaries as a home health benefit, as long as it's related to the skilled services being furnished, is outlined in the plan of care, like I already talked about, and it's tied to a specific goal indicating how such use will facilitate treatment outcomes. So again, it can be part of the plan of care. Next. However, the use of telehealth may not substitute for an in-person home visit that is ordered on the plan of care and cannot be considered a visit for the purposes of patient eligibility or payment. Why does this matter? I mean, ultimately, it matters because it changes the frequency and types of visits thereafter if you're incorporating telehealth into your plan of care. Home healthcare agencies could report a cost of technologies as allowable administrative costs on their home healthcare agency cost reports, and it gives home healthcare agencies predictability in continuing to use telehealth in the future. And really, in my mind, is that this is an industry that needs to have a voice. It needs to have a position within the world of telehealth. Digital medicine and digital healthcare is only growing. It's not going backwards. And I think by not being in that position to have a position or have a voice in that world, it would be a lost opportunity for home healthcare agencies. Next.
All right, sorry, I keep muting myself. Let me get this next polling question. Polling question number 2. Launch.
So true or false? If telehealth is part of the patient's plan of care, then telehealth visit can replace a needed in-person visit.
Lots of people voting, so let me give it another 30 seconds or so. All right, looks like they're mostly stopped. Let me share it with you. There you go.
Okay, so the correct answer was false. You cannot replace the needed in-person visit.
Good afternoon, everyone. I'm Heidi Wall. I am the Director of Hospice Consulting for Healthcare ConsultLink, and I'm just going to go a little bit further than Richard did, just as far as talking about the clinical implementation of telehealth visits. So the importance of appropriate inclusion in the patient's plan of care. I think, Richard, you emphasized that quite a bit, and I want to emphasize it just a little bit more, that we have to identify that as basically it's a intervention in your plan of care. It's how you're going to do your visit. So the agency process for appropriate use of that is staff education regarding appropriate use. So if you think about when you're actually directing your staff and talking to them about when you can and cannot use telehealth visits, you're explaining that to them, that first of all, how is this going to meet the needs of the patient that are identified in the plan of care? So when the patient's plan of care is pulled out and looked at, there are goals there that need to be met. And so if that visit can actually meet those goals or address those goals, then it may be an appropriate use, but it depends upon you know, as you look through, you know, the patient themselves, are they appropriate for that? Do you have the technology to do it? So there's a lot of questions that need to be asked. And so when we talk about visit type examples for that, that may be, for instance, there's an ALF that has said they're scared. They don't want to let anybody in from the outside. They're afraid that you know, that staff may be contagious. And you've gone over with them, your administrator has, the nurses have, everyone's gone through, this is what we're going to do, this is how we screen, this is the PPE that we're going to be wearing. And they still are too concerned about the risk involved and say, no, at this time, we've had too many positives, we've had some family members come in that are positive, and so we don't want to let anyone in right now. Well, that may be an indication that you still want to take care of that patient, and you can address the visit by doing your assessment through telehealth, but you have to document that. So we'll talk a little bit more about that in a minute. The approval flow within the agency. So when you are discussing telehealth visits, one of the things you need to show is that your team, for instance, in hospice in particular, IDG, it's actually a discussion that you had that these are appropriate for this patient, and that is shown in your documentation and therefore included in the plan of care. So there is an approval process that you want to show. It's a team decision. And of course, depending upon your agency, you know, as far as how that flows for those decisions within your leadership. For security and permissions, I think you talked about that, Richard, as far as the security, you know, making sure that if you are using something like FaceTime and you are, as he said, in a public place, that you are protecting the patient information as much as possible. Assessment of the patient's capability to participate. And we talked a little bit about that. You know, is it the patient that you're going to be talking to? For instance, in hospice, a lot of times it's family members, sometimes in home health. And are you assessing their capability of using the technology? You know, are they comfortable with it? You're talking through that with them. The other thing that you need to consider is alternate plans for supply management, because if you are not going in person to that patient and their location, how are you actually supplying, you know, how are you bringing those supplies out to them? Because if you're normally doing that on your visit, you want to actually put a route in place or something for someone in your staff to be the person who delivers the supplies, and that you arrange that ahead of time and the family knows you're coming. And then the documentation of the patient visit and the outcomes. Explain in your visit that not only is it included in the plan of care, but it's actually included as a frequency. We're going to be doing this many visits for telehealth. This is actually how we're going to structure the visit, and this is what we're going to address during that visit. And then you're documenting those patient visits as telehealth visits and what the outcome was of that visit. And then you want to have some place where you're actually recording the types of visits were either in person or telehealth. So you can go back and look at that, because you're actually making sure that you're meeting the frequencies. And if they're recorded differently in your EMR, for instance, your electronic medical record, you want to have a process in place for checking that. Next. The impact on the metrics and financials. So visit utilization. So if, for instance, for revenue and billing implications, this could affect your LUPA. If you are home health. For hospice, it's the SIAs. These are not included, as Richard said, they do not take the place of in-person visits. So they do affect the financial outcome. You know, as far as for service intensity add-ons, you cannot claim them. So that will affect, and you've probably already noticed that. The potential cost savings, though, there is a potential there compared to in-person visits, and that is direct staffing costs. If you have staff that are spread out, they have less windshield time. You can use them for other things because they're not traveling as much. The supply cost, especially personal protective equipment, you know that every time they go out there, they're wearing that equipment. If they're doing telehealth visits, they are actually not using as much equipment, so you can say there's a cost savings there. Mileage, of course, and fleet cars, the cost there is the savings. After hours visit needs, including weekend staffing, they can do a lot of triage. Even if their in-person visit is needed, The triage can be done through telehealth, where you can determine, yes, the patient is declining. I can see that in my telehealth visit, and nurse so-and-so is on their way out there, and you can communicate that to them. That gives them reassurance. Improvement in emergent care, hospitalizations. Clearly, if a family feels comfortable and they've been doing these telehealth visits with you, they feel comfortable calling you and letting you know, hey, can we get on and talk about this before I bring them to the hospital? You know, they know you're there. It's like it's more of an immediate need for them. And that gives them a lot of security to know you'll just hop on and actually go through the visit with them. So even in satisfaction scores, that could actually increase because they really feel you're very responsive as an agency in this process. So there are a lot of pros and cons in this whole process. And here we are, and Charity is going to be talking to you now.
Hi, everyone. My name is Charity Barnsworth. I am the Senior Vice President of Consulting Services at Healthcare ConsultLink. Now, you may see on your screen Heidi in the speaker photo. She and I are in the same room together, and we're trying to avoid the reverb with having more than one line going at the time. So if it looks like she's not talking, that's because it's actually me. But my background is primarily in the licensed and certified or skilled home health arena. You know, I have worked in a company that did have hospice and PAS services, but my background is primarily in operations and operations support for home health agencies. You know, this comes from a variety of different roles. And so one of the things we're going to talk about today is how to look at your operational processes and how to determine which ones, if you have to break them up, how do you prioritize which ones you do on a daily basis, a weekly basis, monthly, and then otherwise. And hopefully you'll walk away with some actionable items, not just information, but things that you can take and put into play in your daily practice. Now, just to start with your operational processes, some key things to think about are that identifying what the most important or key operational processes are for your agency is the first step in monitoring for compliance and effectiveness. That's where you have to look at what is it that we need to be worrying about, because there are so many things in a given day that you could be worrying about. What is it that we need to focus on and make sure that we know what's going to happen, who's responsible, and how we're going to monitor it. Then once you do that, you can decide what are the intervals at which you're going to review those, and you can put that process in place to review them and make sure that things are getting done the way that you would expect. Now, some key things to think about as far as key points. The first one is establishing those agency-specific processes is critical, and you want to document those as standard operating procedures or SOPs. Because when you think about it, every agency is somewhat different. So you can have an intake process, a scheduling process, different processes, but that doesn't mean that your agency will do it exactly like the next one. So while you may have staff that came from other agencies, it's helpful to have those processes documented, because then they're doing things the way you want them done at your agency, not the way they necessarily did them at another agency. Plus, it also gives you the opportunity to say, I gave you the instructions in a standard operating procedure, and in the second bullet point, we assigned specific people and we ensured adequate training. So you have it in writing and you've been trained on what to expect as far as daily responsibilities go. Then you're in the position of the third bullet point where you can say, now we're going to monitor that. You know, I always say in operations, you have to inspect what you expect, because it's great to put a process out there, but the best process on paper that's sitting in a binder somewhere it's worth nothing more than what the paper it's written on is worth. So you have to make sure that the staff are using things and that you're monitoring to make sure, is the process working? And along with that, do we need to make adjustments if we find that it's not working or it's not as effective as we would like? And last but absolutely not least, you have to hold the responsible staff accountable for doing their part, because the only way to have the processes go efficiently is to hold people accountable. If they're expected to do a certain part in the process, then you have to consider if they don't do that, it's going to have an impact on someone else. I like to refer to this also as thinking of it like an assembly line. It sounds very inhuman, but when you get down to it, that's basically what it is. Whether it's the intake process that goes all the way through to the start of care, that goes all the way through to the discharge, if any part of the process is not working, especially if it's because someone is not doing what they're supposed to, Everything else after that is typically impacted in one way or another. And for one, life's not fair, as my mom always said. However, it's not fair to the people around them to expect them to be able to do their part if the others in that process are not doing theirs, because they're going to be impacted in a negative way if that's the case. Now, one of the things that you also want to think about in general is, consider those focused staffing assignments, especially during the pandemic and pandemic recovery time periods. We're going to give you some examples here just, to illustrate what we're talking about. The first one is to think about, if you don't already have this person, who can be a clinical COVID-19 champion for your agency. Now, this person would primarily have responsibility for certain things like making sure that you have the appropriate policies in place, scheduling and tracking the staff education on the policies and procedures, especially for things like the screening requirements. One of the things that we know is that with COVID, the recommendations have been updated regularly, policies get updated because of that. So you want to make sure that you have someone who is tasked essentially with making sure that the agency knows what is it that we need to be following, and how do we make sure the staff have been trained, that we documented they've been trained, and that if they have questions, we know that we can answer those. Then you also want that person monitoring for regulatory updates. Richard was just talking about how certain things were one way back in March, but now they may be different. Those are the types of things that are changing on a regular basis, and they're not even done changing. We don't feel like at this point as a country that we're through this COVID pandemic and national health emergency. So we have to make sure that we're watching out for what other changes will come. That person would also be coordinating with the agency leadership and the other staff on any specific processes. An example of this might be for home health. Review choice demonstration is about to start again. For those agencies that paused, that's very important to know, because if you did take advantage of the pause and you stopped submitting during that time period, you have to be prepared to start again and make sure your processes are in place for that, even though those are not actually COVID-19 specific. Other examples of staffing assignments in the office might be to have a designated screening tracker, someone who takes oversight of the screenings of the staff on a regular basis, and then communicates to the team if there are breakdowns or if there are, trends that are being found during that screening. Another important position on any day, but especially during this time period, is a supply manager. This includes someone who is willing to do what I refer to as closet control. We know that there have been quite a few difficulties with getting personal protective equipment during this time period, but even with that, all supplies are valuable. They cost you money, they can cut into your bottom line, and PPE can especially get not only expensive, but also difficult to find. So you want someone who will control that as a member of the team. And just a designated scheduler. Some agencies are small enough that they don't have a dedicated scheduler, but during this time period, it might be important to do that. So what we're going to do next is we're going to look at what are some of the daily activities that you would want to consider doing when it comes to your operational processes. Now, we did talk and touch on the concept of screening. So it's very important that from that standpoint that you do have staff being screened every day in order to make sure that you're documenting that your staff are asymptomatic and that they don't have any of those other measures that might indicate that there is a potential issue coming, from the COVID-19 standpoint. So that's going to be an important daily process. It can't wait for weekly and it can't wait for monthly. As a part of what you do during the day and how to monitor that would be having a stand-up meeting with key position staff. Now, I come from an organization where stand-up meetings are something that for every year that I was with that organization, we did stand-up meetings. We did stand-down meetings, and we're going to talk about both of those. Regardless of whether or not we're during the COVID-19 time period, having a stand-up meeting every day with certain key members of your staff, not everyone, but just key position staff, is going to be important. In this case, you would be able to update daily on the results of those screenings, as well as other things like your scheduling update. What is the current day's staffing? Do we have any changes from yesterday? You want to ask, have we completed all of the screening contacts for the current day's patients? Have we done those calls to try to screen those patients before someone gets to the home and potentially gets exposed? And did we document those? Think about, for those of you who are clinical like myself, first semester of nursing school, they told us, if you didn't write it, you didn't do it. So you can tell an infection control surveyor, yes, we did screenings, but guess what? If you don't have that well documented, I'm going to be blunt, they really don't care. Because if you didn't write it, you didn't do it. And so the documentation on that's going to be very important. This also gives you a chance to look and as a team at, do we have any reports of any suspected or confirmed infection? And that way you can ensure that the documentation for your infection reports and things like that is being completed, because when it comes time to do your QAPI, those are going to be a key part of your QAPI process. You also want during your stand-up meeting to be talking about where are we at with our supply status, both for patient supplies as well as PPE. But you also want to look at your activity. What happened with yesterday's expected discharges and admissions? Did everything happen the way that was expected, or did something change? Did we have any delays? Do we have what we need from a staffing perspective to make sure that those things can happen? Are we meeting our timely initiation of care? Are we meeting all the notifications we have to do after a discharge? There are all of those things that, again, if one thing doesn't get done, they affect other things. You also want to look at the previous day's recertifications. In hospice, this would be the potential recertifications, especially those that may be questionable, that are not actually confirmed as recertifications yet. And in home health, the ones that we did do for recertifications, were they appropriate, and did we make sure they were appropriate? And did we call and get the approval for the plan of care to proceed? That's something that will absolutely affect you when we talk about orders in a few minutes. So making sure that your staff are following through on the recertification process to get orders is very important. And if you're doing that during your stand-up, you're catching it much more quickly than if you find it later. And definitely last but not least, in a stand-up meeting, you would want to look at even your pending referrals. What's the status of it? When do we expect to admit these patients? And asking those questions to make sure, for one, that you do have an adequate number of staff to take care of what you need to. Now, you also want to look on a daily basis at things like, where are we at with our outstanding physician orders? Where are we at with our unsigned hospice certificates of terminal illness, or CTI? Those are going to impact your billing down the road, and so you want to make sure that you're staying on top of those. I mentioned, for example, that if you're not calling to get plan of care approval on your orders, well, how do you know you have the right physician? That's something that we see commonly when we work with clients, where no one called to make sure that the physician would sign the orders, which means that down the road we're unable to get orders signed, and then we're unable to bill. You also want to look at contact with the skilled nursing facilities on a daily basis for your hospice patients. Asking what's the status of those residents. Were there any changes in their condition that we need to know about? Also confirming the status of supplies. Heidi referenced the limited access, to be able to get into example facilities like ALF, but even with the skilled nursing facilities, we know that they've been one of the areas or types of facilities where COVID-19 has been a major issue, so they may be limiting access. Well, if you have a hospice patient, how are you going to get supplies to that patient that the hospice is responsible for providing? You also want to look at things like monitoring for completion and submission of the required assessments, your hospice item set, or your HIS, your home health OASIS. Those are things that have to be submitted in a timely manner, and if they're not submitted in a timely manner, they can affect other things. On a daily basis, you also want to look at the completion of the pre-billing audits. Is your team looking at what they need to look at to make sure that when it comes to time to bill, you know what needs to be done, you're getting it taken care of, your team is staying on top of it, and they're not waiting a week to do that, because cash flow is an issue right now. And it's already something that needs to be worried about because of everything from PDGM to review choice demonstration and pre-claim review. Even in hospice, you have to worry a lot about cash flow for other reasons. Those are things where if you're not doing your pre-billing audits and making sure that you know what's holding a claim, then you're already behind the 8 ball to get that claim billed and get your cash flow coming in the door. This includes monitoring for the appropriate use of the COVID-19 diagnosis codes. You want to make sure that those codes are being used appropriately, because if not, it could come back to you in an audit situation later. And then just in general, completion of the timely billing for ready claims. You don't want any type of process that's going to slow down actually submitting those claims to get paid. And you also want to look at the stand down process. This is something where if you're doing a stand-up meeting and you're doing a stand-down meeting, you won't have as much to do the next morning necessarily in your next stand-up meeting. However, if you're only doing one of these two, you need to make sure that everything that we talk about in both of them is looked at on a daily basis. Did you have any issues throughout the day that you need to maybe address before you get to the beginning of the day tomorrow? Did you have any reports of persons under investigation or any reports of symptomatic patients, for example? These are all things you have to look at, and also look at, did we have any missed or rescheduled visits? Do we need to do any after-hours admissions or after-hours routine visits or PRN visits? You know, do we have any patients on hospice that are actively dying that we need to be prepared for the on-call nurse to go out? And do we have any new referrals, and what are the anticipated admission dates? These are all things that if you're looking at it on a daily basis and being proactive, you're much less likely to get caught off guard and in a position where you're not running as efficiently, and you may end up with delays and things like that. Now, next, Heidi's going to talk about the weekly activities that we recommend that you look at with your agency processes, and then we'll go back and talk about the monthlies.
Thank you, Charity. So as we look at weekly processes, we talk about maybe case conferences, IDT meetings. We know that they're only required every other week. However, sometimes when you have more teams, you may have these weekly meetings. If you do not, I would suggest that you have at least a weekly touch base with your staff and your teams to do some of these functions, especially during this time of the pandemic. So one of the things, because as we know, as Charity was talking about, that so many things are changing, and your champion, your COVID champion, is the person who's staying on top of that. And so they're looking at education. And from my experience, when you're providing education, even if you're providing it in person, or maybe you're providing it on a case conference online, but if you're doing that and you're going over the education, what's the latest and most up-to-date information from COVID-19, there may be people who are absent from that. They're either out on PTO, or they're seeing a patient, or in hospice, you know, the patient, they're attending a death, something like that, and they're not there. So you need to be following up with those folks to ensure they receive the same education. So having someone responsible for that is really important, and making sure that you're updating that routinely, at least weekly, with what you're finding. Sometimes it's more time sensitive than that, and you have to get that information out to the staff more quickly than just on a weekly basis. Review of certifications, recerts, and discharges. That's always important to go over those. What recerts are coming up, and then what discharges, what live discharges did we have? Did we have any revocations or transfers for hospice, and why did that occur? And review those with your team. And was there anything we could change? Looking at any opportunities for improvement, or, you know, did they leave to go to the hospital? If so, you know, was there something? Could that have been prevented? Was there something that we could have done differently? This is always a good process to have. Reviewing the plans of care for the appropriate telehealth documentation. Again, talking about that documentation, making sure that as you're reviewing the plan of care during your case conferences or IDT meetings, that you're looking at that documentation right there live to see that that telehealth documentation is there. It's included in the plan of care, and in the visit note, it's actually spelled out what PPE they wore, that the screenings are there for the staff, and that the telehealth documentation, there's a reason documented as to why it was a telehealth visit. Review patients with changes in condition. This is always the case. This is standard business in our home health and hospice situations. But the potential impact on PDGM reimbursement, you know, was there a change in condition? Do we change the visits? Do we add visits? Do we add services there? The potential change in the level of care for hospice. You know, are we looking at a family who may need some respite care, and do we need to get on top of that pretty quickly? Or what about maybe continuous care? Do we need to get someone out there to, you know, address some symptom management for that patient? Or are they going to be going to the hospital and doing a GIP admission? We want to be prepared for that, and the team needs to be planning that out as much as possible. The potential triage level changes for emergency preparedness. This is something that should be reviewed at least weekly, because any change in condition can change that triage level. And as we all know, with the emergency preparedness and infection control, these are two large areas with a highly intensive focus for the surveyors this year. You can anticipate that. So they're going to be looking at those triage levels, and were you updating those routinely as part of, did you have a process in place? Because this is part of your policy. And so do those triage levels of those patients match what they look like and the conditions and the assessment that you're describing? The potential need for additional orders, including those for add-on services, anything else that might be happening with those patients. Do they need some therapy, and do we need to get an order for that? Or maybe in a medication change, symptom management, collaborative provider services for hospice patients. In other words, is your patient going to be seeing a cardiologist, let's say, they do this routinely, and they're doing a telehealth visit with that cardiologist? Is it going to be billed through Medicare Part B, or is the hospice going to be paying for it? Is it part of the plan of care? Does it address their principal diagnosis? And if so, do we need to get a contract? All those discussions should take place on at least a weekly basis. The discussion of potential staffing issues for the next week. Is there a holiday coming up? Do we have coverage? Are there any special cases that we're taking on that's going to require some more intensive care, or maybe a particular nurse who does IV therapy? Is that person scheduled? Do we have the correct on-call coverage for the weekend for what's coming up? So those are all good things that you can do on a weekly basis. When you are thinking about, and I think this was addressed in our last session actually, that I think Jennifer addressed when she was talking about the EPP, emergency preparedness plan. And do you have a COVID binder? Do you have a separate binder, separate than your EPP, where you are keeping all the documentation of in-services that you completed, as well as all the information that's being dispensed out there from so many different, the CDC, the WHO, Health and Human Services? There's so much information coming at us. How are you organizing that? Are you putting it in a binder where someone can, if you have a new hire, how do they get caught up? If they haven't been doing healthcare for a while, they may not be on top of things, and that's a great orientation tool. For any of your staff that have been out, how do they get caught up? So having that binder in place that's very organized that they can look at. So that COVID champion could be doing that. So you're actually checking that binder to make sure it's up to date on a weekly basis. Review of reported documentation infections. Charity talked a lot about making sure that you get those screening reports so you know who has a positive infection. You're monitoring for trends. Where are they coming from? Or is it certain staff that maybe is a connection there? You have to look at that as part of your infection control program. And then you're also looking at gaps in the processes related to identification, communication, documentation. When we talk about screening, one of the things that you could be doing is if you're screening if you're screening patients and their family members at home, if you do that, if the nurses, if you have your COVID champion or a scheduler or someone who's doing that, they can actually communicate that out to the staff. And if no one else is coming in that home, that one screening for that patient and family for that day is sufficient, and that can be communicated to the entire team. There may be a social worker and a nurse and a hospice aide that's going out there, all on the same day. If they are, that patient family only has to go through that one screening. And so that's a great thing for them. So monitoring that communication is important. Monitoring documentation for appropriate completeness when we talk about, the plans of care, the PPE is in the documentation, what the staff are wearing, when they go and do their visits. Help ensure readiness for potential infection control surveys. These are coming. There are many of you out there that probably already experienced these and know what types of things they're looking for, but making sure that every infection is documented, all your screenings, everything that we're talking about, they will be looking at. Monitoring your PPE usage and supply stock and availability. That person who is actually your, I think you called it a closet
control person.
Yeah, closet control person. person who's monitoring all the supplies and especially the PPE. And how are you doing that? How are you calculating your PPE? We talked about this in our last session, about how you actually, in advance, you prepare, you're proactive about making sure that you don't run out and that you have enough stock. So someone needs to be looking at that, at least on a weekly basis. Any flexible scheduling arrangements and needing for adjustments, as we talked about before, and staff equipment for remote work at home. If you have any of your staff that are going to be working from home, or if they're actually alternating, like Richard said, with the social distancing, some are in the office this week, some next week, do they have all the equipment they need to be able to do that? And then the remote meetings as substitute for on-site group meetings. Do they have the equipment to be able to do that, to do online meetings? Making sure that that's working and there's a process in place to check that on a weekly basis so there's no surprises when you go into a meeting and 5 people say, well, my computer's down, or it's not, you know, it broke last week and my battery's gone dead and I can't, you know, anything like that. Making sure that you're checking with your staff all the time. And these meetings, on a weekly basis, you can do those types of things. Next. And then orders management. This is really important, as we talked about, certainly for getting paid for what you do, obtaining those signatures on those orders. When we talked about any specific signing physicians or authorized non-physician practitioners, any signatures that you need, are you looking at those, making sure that, okay, so we have our marketer going out this week, and you know, here's a list of the physicians that they can be doing, and then you check back to make sure that you did get those back, and if not, what is your next plan for that? Review of outstanding orders to ensure that they're appropriate. Again, talking about, do you have the right physician in place? You know, especially in hospice, for instance, if you have the patient is naming their attending physician at the time that they come on service. Did we get that order, that CTI from that? Is that the appropriate physician? Or do they not want to sign that order, and do we need to get a change in physician form signed? How do we get that out there to the patient and family? Monitoring issues that, again, talking about the wrong physician, and then identifying specific orders or other processes such as the pre-claim review, making sure that we are starting that and that's in place. Also, pre-claim review submissions, if applicable. What is the status on those pre-claim reviews? Pre-billing audits, both pending and completed. Are you looking at those? Who are you working with? Are you working with your billing person on those and communicating on at least a weekly basis? And posting of those payments. Are they being posted? Do you have a receipt that they've been posted? Pending referrals. Staffing and supply reviews. Are you looking at, you know, if you know what's coming up, is there a specific wound care that you need to address, and do you have the supplies for that particular patient? Level of care changes, as we talked about, and live discharge records. Auditing those before you actually put the claim out there. Did you, if it was a revocation, do you have a signed revocation statement for that hospice patient? And now Charity is going to talk about the operational processes, activities, the review for a monthly basis, on a monthly basis. Charity.
Okay, great. All right, so let's talk now about, on a monthly basis, what are some of the things that we want to look at in order to make sure that we're staying on track with all of the things that are being done on a daily or weekly basis. You know, we've talked about the COVID-19 binder. Like Heidi said, Jennifer addressed it last week when she was talking about EPP, and Heidi referenced some of the key things to make sure you have in that binder. But one of the things that you want to do monthly is let's go through and look at the binder. You know, it's great to have all of that information in there, but if you don't do anything with it, you're not really looking at opportunities for, one, to improve your processes and also identify any potential issues in your agency, such as, do we have an infection trend? You know, if we identify that we had several infection reports, you know, that came in from one clinician, but yet that clinician hasn't seemed to have any issues themselves, how is it that we have a trend with the patients being seen by that person, but, do we need to dig a little bit deeper to try to make sure that that clinician is not unknowingly a part of that trend? Those are the types of things that if you see them one-on-one and just as they occur, it may not give you a big picture that looks a little bit different. So you want to be looking at that binder documentation to see what trends you have so that you can try to make sure that you are addressing them as well as trying to stay ahead of any repeating trends. You also want to look at just your screening outcomes and any need for a process change there. Along with that, you really want to be looking on a monthly basis at, do we need to make any changes to our emergency preparedness plan? That's one of the things we get a lot of questions about at Healthcare ConsultLink is, how do I make sure that my plan is current and that it captures everything that it should? This public health emergency has been an entirely new experience for many people in the business, so they've had to modify their emergency preparedness plans to account for that. But when you think about it, yes, the EPPs are important with the pandemic, but we have them on a normal basis for other sorts of emergencies, and we may need to be making adjustments for those as well. We are in hurricane season here in Texas, and there are other areas that may be represented on the call that go through that same thing, and there aren't necessarily seasons for some of the other things that happen. Weather-related events. We know there's been a lot of, social discourse, and there may be reasons why there's a need in certain areas for people to have in their emergency plan how to address things like rioting and activities like that unfortunately are occurring in some areas and that may need to be a part of the EPP that 6 months ago we would not have expected to need that, but now, again, on a weekly or monthly basis, that could be changing. The other things that you want to do is make sure that, as we've already said, that any of those changes that are occurring, that your staff are being educated and that you have the documentation of that education. This is something to make sure that they have it in their, even in their HR files as you update things that you're training them on, because that's something where you can show, during your QAPI process, during surveys and that sort of thing, that not only were you gathering the information, but you were sharing it with your staff to make sure that they understood it as well. Another thing that you want to consider doing on a monthly basis is look at doing monthly chart audits or clinical record reviews. Depending on the type of agency that you have, you're going to need to do either quarterly or biannual QAPI, and going ahead and doing monthly chart audits will, for one, give you a bit of a head start on that because you'll already be partway there, but it also lets you see, are we finding anything in our charts that indicates that even aside from the COVID-specific issues, do we have other things that are happening that we need to do a better job of, and the sooner that we find it, the better. That's one of those things about if you wait until the 6-month mark, if you're doing biannual QAPI and you wait until the 6-month mark to do any reviews, well, by the time you find it, that issue may be 5 or 6 months old since the last time that you did your reviews, and you're behind the 8 ball when it comes to trying to address it. It also gives you the chance to look at what kind of documentation are we doing to show the PPE worn during our visits. Do we have any issues that could get us in an infection control survey? And are we ready for those surveys? If we get a call today from a surveyor or get a fax from them saying, we're going to come and audit your agency, and by the way, today is Monday and we're going to pick your records up at 10 a.m. on Tuesday, that's not when you want to discover that you have a lack of documentation that needs to be addressed. If you catch it along the way, you're less likely to be in that situation. It also gives you a chance on a monthly basis to look at the implementation and monitoring of any of your performance improvement projects or PIPs to make sure that not only are you implementing what you put in them, but that you're monitoring and you're adjusting based on how they're progressing. Some of the other things on a monthly basis that you would want to do is monitor your customer satisfaction survey outcomes and monitor your CASPER data. Look at those things to see, are there areas where we have room for improvement and things that we could do differently if we made some changes. You also want to be looking at your hospice service intensity. Where are we at with our levels of care in hospice, and do we have changes that we need to be adjusting for or looking for trends that we may need to take action on. And definitely just as importantly, you want to be looking at your billing review. Where are you at with your unbilled claims? What are the trends in leading to billing delays? For example, what are the reasons why we can't bill? Is it an internal issue or is it an external issue? I've spent a significant amount of time in my career in different ways looking at unbilled claims and what's holding them. Is it the physician? Is it things like internal, issues that can be addressed within the agency that don't even require someone outside to do anything? Billing timeliness is so critical now. Even outside of COVID, it was going to be even more critical because of some of the changes that we saw here at the beginning of 2020. And now that everyone has been hit with extra expenses, they've been hit with other things that resulted because of the COVID pandemic, such as, census drops and things like that. Every dollar counts on a daily basis. Every dollar counts even more on a daily basis in the current time. You also want to do that review with your billing company that, we talked about it on a weekly basis, but if you haven't done it on a weekly basis, if you're outsourcing your billing, make sure that where are we seeing denials? What are we doing to try to change those patterns so that we can collect every dollar that we're owed? And just looking at any process modifications that are needed so that you can address any breakdowns that impact your timely billing. Now, last but not least, on your monthly, you want to look at your financial outcomes and your metrics. You want to include your key staff in this also. Now, I'm not saying you have to pull in every member of your team and talk about the financials and that sort of thing, but if they have a part in a metric, you would want to go over that with them. Whether you have it posted on the wall with the old school thermometer graphic where you show them how you're doing towards admissions and restarts and discharges, what's your conversion rate, things like that, or if it's just the internal staff and you want to talk with them about how are you doing with, getting referrals in the door and making sure that you have authorizations and things like that. Looking at those types of metrics on a monthly basis is going to give you an indication of, are you making progress or are you not going the direction that you want? You're always going to be a little bit behind on certain things, because by the time your financials come out, some of these things can't be changed, but it does give you an idea of what do we need to change moving forward to try to make sure that we don't continue to go in the wrong direction. It also lets you look at things like what's your payer mix. Have you seen a notable change in your payer mix? Are you in a position now where you need to do more with things like getting authorizations and improving the documentation that you have to send in? Just different things like that that are going to impact your cash flow. You also want to look at your average reimbursement metrics. This is especially important in home health this year because we did see a change from the PPS model to the PDGM model, and right about the time that everyone was starting to get a feel for their first billings and their first episodes and billing periods and that sort of thing, all of a sudden RCD started in Texas, okay? And all of a sudden COVID hit a month later. And so you have all of these things happening that really make it, at this point, a little more difficult to do that. So the sooner you start looking, the sooner you'll get a feel for what your metrics will look like. You also want to look at things like your level of care changes in hospice that impact your reimbursement and making sure that you have that documentation. Look at your home health utilization changes and your LUPA measures. This is especially important this year. We know that with the therapy thresholds going down, the utilization of therapy is changing. We talk about telehealth and how it's not a substitute for an in-person visit when it comes to, doing that from a billing perspective. You can use telehealth to better manage your home health utilization, because let's say that a patient would normally get 3 visits in a week, but one of those visits is more for teaching and just making sure that they're not declining. We use tuck-in calls in many agencies now to serve as a third touch point for the week, whereas then you go do 2 in-person visits and you do a non-billable tuck-in call maybe on a Friday to help that patient get through the weekend and make sure that they are stable and they don't need another visit that week. Well, telehealth can serve to do that. You won't get paid for those visits. However, if you find that you're in that balance between we don't necessarily really need another in-person visit, but we're worried about the patient if we don't do another in-person visit, that may be when you decide that a telehealth visit is appropriate, and you're not going to be able to bill for it, but it's also not going to come along with the costs that are associated with an in-person visit either. So those are some of the things to think about, and if you're looking at that on a monthly basis, you'll be able to see how you're progressing. Then in general, you just want to look at your financial measures, your gross margin, your operating expenses, your contribution margin, your EBITDA. This gives you a chance to look at what were your staffing expenses, including any overtime. Did you have to use more or less contracts because of everything that's going on? And what were those unexpected expenses? Right now, we're seeing a lot of unexpected expenses with PPE, with patient supply changes. We are also seeing more staff equipment expenses because of what Heidi referenced with the work at home approach. And even in hospice, making sure that you're staying on top of those high cost medications that if they are not addressed appropriately as soon as you find out about them, they can impact your hospice outcomes financially. And then just in general, the tracking of data for pandemic relief financial programs. You know, in our first session, Amy talked quite a bit about those financial programs. She's going to be talking more about that in upcoming programs, including next week, you know, and how to better manage your finances around them. You need to be tracking your data and making sure that you're doing what's necessary, because what you don't want is to find that you didn't do that and then you don't actually have the ability to take advantage of the benefits of those programs the way you expected because you weren't doing what you needed to along the way. All right, now Heidi's going to wrap with the quarterly and other interval operational processes, and then we're going to circle back for our conclusion today.
Thank you, Charity. Okay, so we're going to talk a little bit about your QAPI. Charity touched on that, and we're going to talk about if, for instance, you have a biannual requirement for QAPI, you may want to consider looking more at your quarterly activity rather than a biannual, just to identify potentially negative trends more readily. When we talked about those, you know, infection control surveys and things like, there's a lot more to be looking at and to be focused on right now. There's always something to be focused on, but in this particular case, we know there's a lot of microscopes out there looking really closely at what we're doing in the agencies, and in particular addressing the pandemic. So that may be a good time to actually, you know, increase that interval quite a bit and to be looking more closely. You want to also be following your PIPs and your focus projects and your corrective action plans, and including making sure that that documentation is in there. I can't tell you how many times I see a great PIP written, a great corrective action plan, looks, you know, all laid out, looks perfect, and you think, wow, this is really going to solve something, and then that's where it stays, is in the binder, and it's not taken out and looked at and actually addressed. As if you are actually looking at that and you are monitoring the progress on that and you are inspecting what you expect in that, as Charity said, then you will find that either you're not addressing the interventions and action plan that you put in place, and the only way to do that is to monitor that. So at the very least on a quarterly basis, if not more often. Your QAPI committee meeting is usually completed on a quarterly basis, and you want to be looking at every aspect of that and making sure that you have that infection control focus in your QAPI that we talked about last week. The preparation for expected changes in your cost report process. I know Richard touched on this, but we can actually include the telehealth, you know, communications, the communications, all the technology that's involved in that, any of the equipment or any costs in that can be included in your cost report. And it's actually put, you know, it's under like other patient services. You can put that in the PHE COVID cost center in your cost report. And also to be aware that, you know, the cost report due dates have changed, and so as we are aware, the second one is coming up for the fiscal year ending in December 31st. That's coming up now on July 31st, so that's been delayed, but it is coming. The readiness for processes being restarted after pandemic pauses. Yes, they have come back, and they're coming back in full force. August 3rd, regardless of the PHE status, is what they say. So we know that TPEs, ADRs, they're coming. So the thing that you can do to prepare for that is, first of all, in your QAPI process, doing your monthly audits, looking at your charts. If you're doing the pre-bill audits, you know which payments are at risk for you and what you can do about those, and being proactive with that. And the review choice demonstration that's going to be restarting on August 31st. And I know many of you probably haven't paused, but if you have, you need to be aware of that right now. I think we have a polling question coming up. Yes. Amy?
All right. Poll question number 3. I'm sorry, can you hear me? Good?
Yes, we can hear you.
Okay, cool. Here goes.
So what has your agency experienced as the most significant challenge during the COVID-19 pandemic? I know there are a lot of challenges, and we talk about them on a weekly basis now, but what we're hoping is that some of the things we have talked about will address some of the things you do consider significant. So the first, scheduling and staffing challenges. Is that your most significant? Access to patients and clients, ability to maintain your census, your reduced referrals or increased discharges, the day-to-day cash flow changes that you have, or staying current with constantly changing recommendations and waivers. Is that a big challenge for you? Or is there just another topic that we haven't touched on or talked about, or we'd like to know if there's something else that's a big challenge to you. So please go ahead and vote.
Looks like quite a few are still voting. So let me give it a few more seconds.
You have to read that one quite a bit.
Yeah. That's why I always like to read it to them. I know I don't like reading, so if somebody reads it to me, it helps me get engaged to answer. So, all right, that looks good. We'll shut it down and let me share the results.
Interesting. Okay, staying current with changing recommendations and waivers. I did actually think this might be I predicted that might be. It's 38%, guys, and then scheduling and staffing changes is right behind with 28%, and then behind that is the census. Access to patients, that's good. That only 9%, only 7 people responded as a big challenge. I'm glad to hear that. It's good to know. When we're in healthcare, we want to know those patients are being seen, if at all possible, and their needs are taken care of. And then the last one, another topic, just a couple people have said that. So I hope you can share that with us if there's anything that we can address or answer your questions. So we will have some questions coming up, and Charity's going to take it from here.
Yes. And so before we start the Q&A, we just wanted to give you some additional information on the screen, and it is in the slide deck that's available on the Pandemic Webinar Series website. We have obviously given you a lot of information, and we know we've had to give you a lot of information in a short time period today, but that is because we did want to give you a lot of usable information. But we are available if you have additional questions after the call. We'll answer what we can with the Q&A, but then you also have our contact information here for Richard at DLA Piper, as well as Heidi or I at Healthcare Consult Link. You have our information there. And then we do want to say a very big thank you for those of you who joined today, because we know that your time is valuable, and we know that we have difficulty getting away to attend webinars. And so the fact that you've attended, we very much appreciate that. And we do hope that you will join us next week on Thursday for Amy's next presentation, which is getting prepared for the next round and financial considerations. Amy's going to talk about everything from banking relationships to the importance of adequate cash flow and savings, optimal debt management, budgeting, and meeting the required filing requirements. That's going to be, I think, a very informative talk as well. And so we do encourage you to go to the webinar series website to register. If you have any difficulty, there is also a number and an email address there where we have someone available to help you if you do have difficulty with registering for one of the sessions. Now, we will go ahead and open it now for Q&A. It looks like we do have some questions waiting, and so Amy's going to help facilitate opening that up, and then we will see what the questions are and who we need to ask to address those. So Amy, why don't you go ahead and let's see.
Sure.
Okay, I can see them now.
Okay.
Okay, so someone had asked the question, are digital signatures allowed when office staff is working remotely? I'm not sure if you mean digital signatures on like client or patient documentation versus staff actually being asked to provide information. If it is patient or client specific, for example, when we go out and do home health and hospice visits, it's a best practice to collect a signature, but it's not a requirement. Now, if you're talking about for office staff related activities, that would really, with the limited information in your question, as far as that goes, I think what we could say is it depends on what you're asking them to do. You know, if you're asking them to sign off that they have done certain parts of the process, that's really going to be agency specific as far as how you have them document those processes anyway. Richard, do you have anything else you would want to add on that when we're talking about staff working remotely and a need for digital signatures on anything?
You're on mute, Richard.
Sorry about that. I was, so obviously nothing specific. I mean, as it relates to the physician, to the signature, just making sure that it's valid and that it's under a secured system.
Yeah.
Okay.
All right, the next question says, I understand as an RN the need to educate and screen in our case with PAS only, but it seems that the state is making us, the agencies, responsible and accountable for all that is going on in the client's home, provider's home, nursing homes, et cetera. We don't have the manpower to do that, and as a member of TAC, I hope somebody will advocate for us. I know that's more just a statement versus a question. I will tell you that we are members of TAC. I personally sit on 3 different committees for TAC myself, and I will tell you that, that TAC is doing a great deal to try to advocate for the agencies, and they are every day putting out information about things that they are doing to try to make things as workable for the agencies as possible. You know, I would say if you are not a member of TAC, we strongly encourage you to consider it because they are doing a great deal to keep everyone informed. And they actually, we at Healthcare Consult Link, we have looked at multiple state association websites through this process, you know, because we do business in multiple states, and TAC has some of the best updates and resources and member information available of any of the states out there. And so, you know, again, I do believe that they are advocating, and those of us who are in a position to help do that are certainly going to continue to do that. Someone also asked, can staff education be given by email? For example, sending group emails to all staff. I wouldn't say that that is optimal, but it is definitely a way that you can communicate information out. What I would recommend, just personally from having worked in, you know, positions of education, you know, or where we were doing education regularly, is if you do put something out by email, whether it's in the body of an email or you send out an attachment or a training document, what I would do is I would have the staff send some sort of an email response that basically says, I did receive the email, I did review the email, and I am attesting to the fact that I understand the email and I don't have any questions about it. It's in a way, it's a way of getting that digital signature if you want to look at it without them having to sign something. It's a way for you to say, I can hold you accountable because you sent the email back saying, A, you got it, B, you read it, and C, that you do understand it and you feel like you don't have any questions or you sent back questions that we addressed. I think that's one way to look at it. So, Heidi, anything else to add on that part for this? Okay. Now, the next question is, are you going to make all the webinar materials or handouts available at the end of the series, or is it going to be upon request? At the webinar series webpage, each week we're adding a recording of the session as well as the handouts from the session. Those are going to stay up there. The recording ends up being hosted on Amy's and Night CPA's YouTube channel because that was a great way for us to keep those hosted. They will stay available through the recording links, and we will have a PDF version of the slides every week so that you can have those handouts. That way, if you're not able to attend live or you have to jump off or something, you'll be able to get those and go back and review them if you find them helpful. So yes, absolutely, and we will keep those up for quite some time so that anyone who wants to go back even a month from now will be able to do that.
Yeah. And when the webinar closes, at the close, you will be redirected to that website automatically. So you might bookmark it, but I've also put it in the chat panel, the link to the website.
Yeah, and that's a great point, Amy, that they will be able to get to it easily that way, and that way they can save it. So, okay, here's a question about hospice. What are the recommendations for testing hospice staff that have not had exposure or symptoms? The skilled nursing guidance that CMS put out indicated that hospice staff should be tested as well. However, they did not give any recommendations on how we should test.
And I'm going to throw that to you, Richard. I'm going to ask you because I am not familiar with this guidance as far as testing people who have not had an exposure or symptoms. And I don't know if they're asking what type of test, as far as approval or how often. Do you have any recommendations, Richard, on that?
Sorry about that again. The testing, it's actually specifically in the CDC guidelines. If they're asking for the specific type of test, I don't really have, a specific test in mind, but it does have to be, I would go to a reputable location that, and every location has different types of tests. I actually represent different clients who do the testing, and I've talked to them about the actual test. And obviously, if you have one that's been through FDA review, then that's going to be, obviously more regulated than one that isn't. But the specific guidelines I don't have it memorized, but it's actually listed on the CDC guidelines. They do provide some very detailed step-by-step on how to handle that.
I think to add, Richard, to what you're saying, I think that one of the things to keep in mind too is that there are daily screening recommendations, to screen the staff. And I think that's something else that if you'll follow the recommendations for screening of staff, then that will also tie in with any testing that's done to show that the person was asymptomatic, didn't appear to have any exposure or any reasons why they would be considered higher risk also.
Right.
And I'll just add one more thing to that is that if you have employees and you're just going across the board to screen everybody, there are some very specific limitations that under the ADA. So just be careful with that, and that's something that needs to be really looked at on an individual basis.
Yeah, great point, Richard.
Mm-hmm.
All right, the next question is, what happens if you have a suspected or confirmed COVID-19 patient and you do not have any experienced staff member? Can you substitute telehealth visits? I think that is going to fall into that category of where you establish what guidelines are you going to use for telehealth visits and what's ordered for the patient. If it's something like wound care and there's no one else to assist in the home or be coached to do wound care, you're going to have a more difficult time substituting a telehealth visit and accomplishing what needs to be accomplished for that patient. That's going to be where you have to look at what the patient's plan of care is. You need to collaborate with the physician because you're going to need to make sure that telehealth is in the plan of care anyway. So you would want to have that conversation with the physician to discuss the patient's circumstances and what's ordered in the first place and make sure that everyone's on that same proverbial page about using telehealth. You also have to keep in mind, none of those visits are going to count as billable visits. So if you are taking care of the patient and you're doing it via telehealth because you feel that's appropriate and the physician is okay with that, as well as the patient, then you have to understand at that point that you're doing a completely non-billable care, episode billing period, whatever it is, depending on what service line it is. And, that may be what needs to be done, but just make sure that you go into that understanding that. Heidi, anything else from the...
Well, I would also add too that, the reason that you're doing a telehealth visit is patient generated to address their needs, not your staffing needs generated. Yes. So you may have to be looking elsewhere there are certain situations when you can contract with staff if you can't find someone for a specialty. But I would make sure that if this is a patient-centered approach to the care, to using a telehealth visit. Richard, do you have anything to add to that?
No, not at this time.
Okay. The next question that we have, Richard, this one's going to be for you. Yeah. If an employee is told to stay home from work due to symptoms which after testing was other than COVID, so in other words, they tested negative, is that compensable time? Okay,
so I looked at this, and just as a matter of clarity and as a matter of thoroughness, I think what you're asking is that the time that the employee is away for the testing, is that compensable time after the employee had expressed some symptoms? Is the time away for the testing for COVID? And then, of course, when the COVID test came back negative, is that period is compensable time. That period is compensable time because it's related to the communication as it relates to, hey, I may have COVID because I suspect that COVID has affected my health. I need to go get tested. So that can absolutely be part of that EPSA bucket of time as that first group of time. If nothing has been, if it's available. If it's not available, then you have to look at some other buckets of time. Now, if you're asking after the fact, if they're test negative, they still continue to show symptoms, but the test is negative, then you defer back to your usual company policy because it's no longer COVID. The reason why they are expressing symptoms and the reason why they're sick, it has nothing to do with COVID. Then it goes to whatever your sick time is for your company's policy, and none of the statutory limitations or statutory requirements as it relates to COVID is applicable at that time.
Okay. All right, and the next question that we have is, I had a staff member that tested positive for COVID, but did not provide the agency with information until after she got a negative result. What do you recommend that we do as an agency? Richard, I'd actually ask if you would start from the employment standpoint on this. We can talk clinical after that, but obviously that staff member did not do them a favor. I'll start with that.
Well, first of all, it sounds like the staff tested. They tested positive, but did not provide agency with information until she got a negative result. So I'm not. I guess did they? Charity, do you understand that question? Whether it's a positive or a negative result?
I am reading that as the staff member tested positive, but until she got better and came back with a negative result, she did not tell the agency that she had tested positive, which the way I interpret that question with the information provided is that means that staff member could have been in contact with other staff members as well as patients or during that time when she was positive. So. Right.
No, so this is, I think during my presentation, this is where you during the beginning stages of COVID, it would have been really helpful for you to beef up your policies and procedures, is that you actually have a policy that requires the employee to provide information or to express they've either tested positive or they suspect that they've been around other people who have COVID, and that they are potentially a candidate that could test positive. So as an agency, first of all, I think it would be recommended that you get the records from both the positive and the negative, and make note of the dates of when they tested positive, and make notes of when they tested negative. I think as an employer, you do have a duty to minimize to minimize the dangers of it. I don't know how much more you could do, because if you tested positive and then you didn't know about it as an employer, and then you find out about it at a later time, arguably that one employee staff has already exposed a bunch of people to potential positive coronavirus. So it does create some predicament there. I think that if you do have a policy that requires an employee to do that, that is an indication of, I don't know why an employee would, I guess the employee was trying to circumvent around the fact that they didn't want people to know. Arguably, that is grounds for termination, because you are exposing that danger to that employee. And, of course, I would need more facts, but it's not I don't think it's a very good set of facts for the employer, just because it could potentially spiral to potentially a pretty big deal, depending on what happens thereafter.
Right, and I would add to what Richard's saying, that from a clinical perspective and a clinical operations perspective, what I would suggest is, once you establish the date that the employee tested positive, and if you know when they were symptomatic even before that, and then the date when they were deemed to be negative, I think in that case, you would really want to go back and look at who did that patient have contact with, both as a care provider, but also, you know, even from the staffing perspective, you know, did they come to case conference and sit right next to somebody and share pens and whatever else that we know is potentially putting people at risk, and look at, did you have anyone else during that time period in those groups of people, you know, who may need to be screened additionally, or identified, you know, based on what they provided in their screening, you know, because that may help you discover the source of an infection if you did have a subsequent infection or an additional one to go off of. Heidi, anything else?
Oh, I'm sorry.
That's okay, Richard, go ahead.
I was going to add just a little bit to that. You know, a couple other things I think you should do as the employer from the employment side is that after you get more accurate information of the dates of when this staff tested positive compared to when she was negative, then you have a very truncated section of time to where you need to sit down with this employee to gather as much information as possible to see where along the way during that time there was exposure. And then if you know that this staff has exposed other employees, you should provide notification to those employees that there's been a situation where we suspect that you've been exposed to it, and that you should recommend that they go get tested for it.
Yeah, definitely. And I think we're going to have a little bit more discussion on that, judging by the questions coming through. Now, we have one person who's all they typed was COVID testing, so I'm not exactly sure what that means. If you would like to ask with additional information, by all means, you know, feel free to post again so that we'll know exactly what your question about testing is. Okay, the next question that we have, and I'm finding myself flashing back to a conversation I had with one of our client agency owners about 6 weeks ago, you know, because this exact scenario happened, not the same agency, I can tell by the names, but what happens if someone went on vacation and came back with symptoms? I asked them to stay home and get a test. The pending result time, like while they're waiting for that test result, is that sick time for them, or is it compensable as they got it while on vacation and not during work? So in this case, Richard, they go on vacation, they come back with symptoms. The date that they were supposed to return to work, they can't because they're still waiting on the test results to say, do they have it or not? Is that time that they would have otherwise been working compensable, or do they have to take that as sick time because they became symptomatic while they were on vacation?
So if you're on vacation and you're scheduled to come back on a set time period, then at that point, once you receive notification of the staff being sick, then again, you have to defer to, well, what is allowed for what bucket of time is allowed. So if they haven't taken their up to 80 hours or the 2 weeks under the EFSA, then you can obviously tap into that, because if they're sick, that's actually exactly that first bucket of time that they can use. If they utilize that, then you're going to have to look at the second bucket of time, which for the FMLA, assuming they qualify, right? So under the extended family leave, they have to work there for at least 30 days. So you have to look to see if they're even an eligible employee to take that time off. And of course, if they can, then great. If they can't, then you have to defer to the third bucket is they're going to have to tap into their PTO and or their sick time, you know, consistent with whatever your company policy is.
Okay. All right. Let's see. Okay. So someone says, if the employee was told to stay off work due to an illness and on their own got tested and was negative, should they be paid for those days, 5 days in this case, in which they were ready, willing, and able to work, but were told to stay home during that time period? Richard?
I got the same answer.
Yeah, that will be the same answer.
I just wanted to make sure.
Whatever I said just now, apply the same answer.
Okay, there we go. Okay, someone also says, my question is, are healthcare providers exempt for any leave?
They can be. You're not required to offer the emergency paid sick leave to healthcare providers. You can, but you're not required to.
Yeah, I mean, I'm just looking at the questions. My question is, are they exempt? No, I mean, they're not exempt.
Well,
But
that's how that act read. Healthcare providers are exempt.
okay, I think I know what's saying. Okay, they're just simply asking, are healthcare providers exempt from having to apply that law? Yes. Okay. Yes.
Okay. Okay, the next question that we have is, are COVID results considered medical records and need to be in a separate file?
They are considered medical records, but here's the thing: they're actually not covered under. Well, I know this doesn't answer the question, but they're actually in this situation, HIPAA doesn't apply if that's what you're concerned about. But if you're asking whether they should be in a separate file, there's no regulatory requirement per se that they have to be in a separate file. They have to be in a secured area and it's good to maintain confidentiality. And it's not even for the purposes of HIPAA. It's actually for other reasons. But here's the thing: if you keep it in a separate file, you can distinguish that from the personnel file. However, if you keep it in a separate file, that also increases your chances of that's one additional file that you have to be concerned about to maintain the security, the physical security of that file, if that makes any sense. So you're not required, but you can.
Okay. Okay, the next question is, we are a private pay only PAS agency. We have a policy that we do not accept COVID-19 clients and that our employees do not attend to COVID-19 symptomatic or confirmed clients. Do we have to pay an employee if their client becomes symptomatic and we do not allow the employee to work? Richard?
Okay, so how I'm reading this is that if the client becomes symptomatic, they're sick, and we don't allow the employee to work, the question then becomes, does the employee work on something else on behalf of the agency? And if the answer is no, then any time they don't work, it's not compensable time, because there's no requirement that just for the client who's symptomatic that impacts the workload of the employee. That doesn't really fall under any of the regulations as it relates to COVID.
Okay. Okay, and then the last one is more of a comment, and I think there's probably more people on this call who would agree with this based on the questions that we're getting. Someone said, we would really love an in-depth session on the various laws, EFMLPA, EPSLA, and the FFCRA, specifically the agency's responsibility for paid leave, because it is very confusing. Now, Richard is going to be doing a legal focused session. I believe it's 2 weeks from now. Let me pull up the list. Hold on one second. We are going to have on session 5 on July 30th. It's the legal aspects of pandemic recovery. Now, Richard, I'll let you share how much of that you're going to get into in detail during that session, but that is going to be all legal that day. So Richard, are those things that you'll be covering on July 30th?
Yeah, it will be a little bit more in depth. I mean, today was just really touching on it. What really helps is if you actually have some case studies so that you can go through some fact patterns. What I can say is these laws are very specific to very specific circumstances. I think in one of the questions it asked, it asked about the return to work and what buckets of time. Well, as you can see, based on my answer, there's different layers you have to look at. You first have to even look at to assess whether the employee is even eligible for one of the buckets of time off. So it does become very fact specific, and it changes. And for the purpose of this presentation, obviously, because of time and because of limitations, we weren't able to dive too deeply into it.
Okay. Okay, and it looks like the last question that we have today is it legal to have a policy state you won't accept COVID positive patients?
I wouldn't have that policy.
That's pretty straightforward. Okay. Okay, well, why don't we give it another few seconds just to make sure there aren't any last questions. I know some people had to drop off, but hopefully they'll know they can go to the recording to listen to the rest of the Q&A after our originally scheduled time. But we're glad that everybody stayed on with us, and it doesn't look like we have more questions coming in, so we'll go ahead and wrap for today. Thank you again so much for coming, and if you would, please make sure you check out the registrations opportunities for the subsequent sessions, and we look forward to seeing as many of you next week as possible. So thanks everyone, and have a great week.
Thank you.
Hi,
Thanks.
everybody.
Bye-bye.
Bye.